No problem. Posterior polar, no problem. I will make you all right. So I went and did my viscoelastic injection. I've done my hydrodelination. I removed my nucleus, and at that time, I'm just wondering, when can I go home for lunch? So I removed my epinucleus there, and you can see so far so good. Now, you see, all I should have done at this stage now is stop, change from the phaco probe to an IA probe. Now at that time, I'm thinking of my lunch, so I want to go faster. So watch what I'm doing. I'm using my phaco probe for the subincisional area. Gone. Now let's see this again in slow motion, and you can see from this what a terrible surgeon I am. Instead of spending that 5 seconds to change the phaco probe to IA probe, I'm now wasting 5 hours and my lunch is also gone. So now what do? I go in with my vitrectomy system, and you can see I'm now using my vitrectomy probe to clear up this cortex and the epinucleus. So always have fluid in the eye. We have just started a new system called the trocar AC maintainer. At that time I did not have it, so you can see in my left hand I've got fluid with a cannula, but I'll talk on the trocar AC maintainer later on, and then you can put any lens of your choice, regaining paradise. Now let's see another case here. Again, posterior polar, and you can see now what I'm doing is, I've done my rhexis, so far so good. Now I go for my hydrodelination, but watch carefully, my cannula is parallel to the rhexis. It should have been oblique. If it is oblique, it produces a hydrodelination. But since it is parallel, watch, I've created a hydro dissection. And now what happens? I'm going in, removing my nucleus, and all I get is nothing but a rent. And that is increasing in size, and my heart is sinking also in size at the same time. So now I go in for my cortical aspiration. I remove the cortex, shift back to the vitrectomy probe, and using the vitrectomy machine and the probe now, I'm removing this, clearing up all the subincisional area also. Now you can put any lens of your choice. Now let's look at another case here. And this was another very important patient who had come to me. And you see, I've done the endonucleus. So far, so good. Once I remove the endonucleus, I'm trying to remove the epinucleus. And again, I'm trying that stupid trick of mine, which is wrong. But watch, I'm lazy. I am dumb. And I'm a bad surgeon. That's a very dangerous mixture. Watch what I'm doing. I'm rotating the epinucleus. So ladies and gentlemen, if you see posterior polar, it's like a torque. You'll create a torque if you rotate it. No PC rupture till now. The moment I have rotated that epinucleus, I'm trying to now remove this epinucleus, and now you can see what's happening here is, there you can see that epinucleus coming out, but look behind. I have a large rent just because of sheer laziness of me going in and trying to remove that epinucleus by rotating it. Finish off the cortical aspiration, clear it up, and then implant another lens of your choice. Now look at the next case which I am going to show you, and you see here, this was another, somehow these posterior polars turn out to be very VIP patients. I've removed that endonucleus, but watch carefully now what happens here. I finish the endonucleus, and watch, I pull out fast. The moment I have pulled out fast, my chamber has collapsed. When my chamber collapsed, I went inside to remove my epinucleus, and because of that sudden change in anterior chamber depth, sudden collapse of the anterior chamber, oh boy, that epinucleus is going down and down. So now you see I have got an epinucleus sinking there. Now what do I do? So now at this stage I had not started the scaffold technique yet. So what I do is I decide now, let me see, I still have some epinucleus down there. So I take a 3-piece intraocular lens. And what I'm going to do is I'm going to first of all implant my 3-piece IOL into the sulcus. So I'm going to check how much of sulcus I have, and once I know I have enough sulcus, I can easily fix this intraocular lens in the sulcus. Case not over, ladies and gentlemen. I still have to remove my epinucleus. So what I do is I fix my infusion cannula. If you notice, this has a chandelier light installed with it. So it gives me light, plus it gives me infusion. And this gives me a big advantage because I will be able to do my vitrectomy now with good illumination also. So you can see now, once I've got that fixed, I'm going in, doing my vitrectomy, clearing it all off there. And once I have done that, you can see now I'm going inside, doing my anterior vitrectomy. Now I go to my posterior vitrectomy, and you can see my light illumination is there. So I can go in, remove this epinucleus, which is lying right over the macula. So I go in on that in an aspiration mode, a technique which we started called SPAL, sleeveless phaco-tip assisted levitation. Remove that, and this is how the case looks when it is completed. So look at this other case of posterior polar. When I started the first case of posterior polar, I showed you a lovely simple posterior polar. This is like a Frankenstein or a Dracula posterior polar. It's a dense posterior polar. So now what I decided to do, I am stupid. So at that time I was doing phaconet, which is sub 1 millimeter cataract surgery. So I said, okay, I'm going to do phaconet in this patient. So look at this now. I've got in my left hand irrigating chopper. In my right hand, I've got a 0.7 millimeter phaco needle. And I'm going to go in and I'm trying to remove this nucleus from there. Now watch carefully. Suddenly, I press the foot pedal more than I should. So now, suddenly you can see smallest PC rupture, 0.7 millimeter PC rupture. I should have simply done an extra cap. But no, I wanted to try something like this and see now what's happening. My nucleus is going down and down and down. So you can see as things are happening, my life is going from the frying pan to the fire. So once my rupture is increasing like this more and more, I do not know what to do. As you can see, it is just sinking. Now, at this stage, I don't have much of a choice. I have to go again to the vitrectomy systems which I have, because without that, that nucleus is not going to come out, because now they have a nucleus also with it. It's just not epinucleus. So I now install my first is my intraocular lens, and if I have enough support, I'm able to implant my lens. But again, case not over, because I still have got my nucleus lying on the retina. So what I do is I go ahead, do my vitrectomy, and once I'm doing my vitrectomy, again you can notice that illumination which you are seeing on your upper right is the chandelier light. So that gives me a good panoramic view, gives me good illumination, and you can see I'm using the SPAL technique after doing a vitrectomy, and with this I can then remove this whole nucleus there on an aspiration mode also sometimes. Once that's done, check the peripheral retina. Do you have any breaks? So I'm checking that up also. You can see disc, macula, case looks good when it's completed. And how did the patient behave? And you can see nothing right what I did, but somehow the person on the top helps us. And you can see 1 month post-op, the vision is 20/20. And you can see this is how the case looks when it is complete. Saying this, ladies and gentlemen, what I'd like is to ask Dr. Atya to come and speak on her complications, and then I will come back again to finish off the rest of the session. Dr. Atya?